Hi, and welcome to the Institute for Global Health Sciences Grand Rounds. I'm George Rutherford. I'm the acting executive director of the Institute, and it's a pleasure to welcome our Grand Round speakers. Before we do that, I'd like to acknowledge the traditional, ancestral, and unceded territory of the Ramatash Ohlone people, who are the traditional custodians on the land on which we at UCSF are living, learning, working, building community, and organizing today. Our speaker today is Dr. Madhukar Pai, whom I've known for a few years. Dr. Pai attended medical school in Vellore, I assume at Christian Medical College. That's the only one I'm aware of that's in Vellore. He completed his doctoral degree in epidemiology at Berkeley and was a postdoctoral fellow at UCSF. Dr. Pai is currently a professor at the as one of the Canadian Institutes of Health Research endowed chairs, and is a professor at McGill University in Montreal. He serves on WHO's Strategic and Technical Advisory Group for Tuberculosis in the Southeast Asia region, and the WHO Advisory Committee on Tuberculosis Diagnostics and Diagnostics and Laboratory stuff. He's a member of the Scientific Advisory Committee of FIND, which is one of these big parastatal organizations in Geneva. Serves as the chair of the public-private mixed working group of the Stop TB Partnership, and serves on the editorial boards of Lancet ID, PLoS Medicine, BMJ Global Health, among others. And he's the editor-in-chief of PLoS Global Public Health, for those of you who are looking for where your next publication should go. His research is mainly focused on improving the diagnosis and treatment of TB, especially in high-burden countries like India and South Africa. He's supported by grants from the Gates Foundation, Grand Challenges Canada, and the Canadian Institutes of Health Research. He's a recipient of the Union Scientific Prize, the Chanclani Global Health Research Award, the Haile Debas Prize, and the David Johnston Faculty and Staff Award. He's a member of the Royal Society of Canada and a fellow of the Canadian Academy of Health Sciences. Madhu's a very impressive guy. And he's, as I said, he's the Canadian Research Chair in Epidemiology and Global Health at McGill, and the Associate Director of the McGill International TB Center. And I actually think I was on your dissertation committee, but I don't really remember. It's too long ago. And our discussant today from our master's class is Rebecca Kaufman, who will be leading the discussion. Rebecca attended American University, I just found out. And we're delighted to have you. Thank you for coming. So, Professor Pai, take it away, if you please. Thanks very much.
Thank you, George. Thanks, everyone. It's a pleasure to be back here at UCSF, even if it's virtually. I can't believe the last time I spoke was in February of 2020, just before everything went crazy with the pandemic in March. So if you remember my talk last time, we had really discussed about how to address this growing momentum in decolonizing global health. And I know IGHS has had a series of talks exactly on this issue. Mike and others have coordinated that. And along that series, I'd like to share with you some of my current thinking on allyship in global health. And I hope it will be helpful for you, because it is certainly helping me think about my own work and my own positionality sitting here in the global north, like most of you, and yet interested and excited and wanting to make a contribution to global health issues in low and middle income countries. I have been thinking a lot about two problems, and I'm sure many of you have as well. I think it's clear from the pandemic that we've seen that we live in a deeply unequal world, and only made worse by the pandemic. That's a fact. But I think the problem is our field of global health is also equally unequal, and that makes it impossible for us to truly tackle problem number one, right? So we are in a bad shape, I think, because global health attempts to address inequities in an inherently deeply unequal world with a field that continues to be inherently inequitable. And so this is a problem that seems practically not soluble, but I think we should all be worried about it and thinking about it as people who are interested in global health. So let me just dive a little deeper into what I mean by problem one, the problem of living in a deeply unequal world. And I don't think there is any better exemplar of how deeply the world is unequal than the COVID vaccine apartheid or inequity that we are living through right now. So this is me last week, taken in India. I went back home to India, my other home, for the first time since the pandemic began, and saw my mom, who's 83 years old, for the first time in 2.5 years. And I just don't know how she survived the brutal pandemic in India. I can only ascribe her survival. I'm pretty sure she got Omicron, but she was vaccinated and boosted. And I think this played a massive role in her still being alive. And for me to see her after almost 2.5 years. And I asked myself, why is it that my mom lucked out, right? She was extremely lucky to have had access to vaccination, and it clearly made a massive difference to her life story. But probably 5 million Indians were not that lucky. Estimates suggest that regardless of the government of India's claim, where only about 500,000 people died, the reality in India is that probably 5 million Indians died during this pandemic. It's at least 10-fold higher than the government of India estimates. In fact, last year, just around this time, mid-April, the Delta wave started in India, and it was absolutely catastrophic. I cannot explain to you in words how desperately bad things in India were. And currently, when the dust settles, it seems like India lost something like 3 million people in 3 months, April, May, and June of last year. That's how disastrous this pandemic has been for people. And I really, really have no way of explaining this, but to ask myself, so if my mom was lucky to get vaccinated and survive a brutal pandemic in India, why shouldn't everybody else's mom have the same chance? Why shouldn't everybody else's dad have the same chance? Brothers, sisters, whoever they are, everybody in the world deserves a chance to survive. And vaccinating the world should have been our goal right from get-go. And here we are, almost in April, May of 2022, nearly a year and a half since vaccination rollout started. And this is the dismal progress we have made in low-income countries, while high-income countries and upper middle-income countries have done so well. This is a very, very inequitable situation, and it has left nearly 3 billion people waiting for their first dose. Only 15% of the population in low-income countries have received even one single dose during this crisis. And you can see where those unvaccinated millions and billions are. It's primarily the global south that is bearing the brunt of this inequity. And we have seen this before. This is not a new story. This is a piece that colleagues and I wrote in the Atlantic magazine, where we said, when those of us, people in the global north, who probably presumably triple vaccinated, are declaring the pandemic over and thinking that it's okay that these infections become endemic, we've seen exactly what this could have happened in the past through AIDS, TB, and malaria. At one point, AIDS, TB, and malaria were very common here in the global north, but the minute they ceased to bother us, we declared success, we stopped investing in these infectious diseases, we've allowed them to become endemic in the global south, where they're still killing millions of people even today. And so COVID-19 is going along a very predictable and depressing pattern, where the global north gets to dictate what is or is not priority. And so here is something that Peter Sands, the CEO of Global Fund, had written, that HIV, TB, and malaria are pandemics that have been beaten in rich countries. allowing them to persist elsewhere as endemic infections is a policy choice and a budgetary decision that we all make. We've decided that it's okay to have so much TB in the global south or so much malaria in the African continent. And there is no clearer explanation of this than this graphic from the Stop TB Partnership. At a minimum, the investment in COVID vaccines is 1,000-fold greater than TB vaccines in a century, which is why we are using a century-old vaccine even today for TB, while we've had so many amazing vaccines developed for COVID-19 in a short span of 2 years. So I'm starting to think, seeing what I have and what you have over the last couple of years, I refuse to believe that science and resources are not the rate limiting steps for ending TB or any global health challenge. They're not. If we wanted to R&D something, we could. If we wanted to invest in something, we could. If we wanted to get it out quickly, we could. But we still choose not to do it for a whole host of things. And I think the real problem is our value system. And the late Paul Farmer has been writing about it for a very long time. In one of his books, he writes, the idea that some lives matter less is the root of all that is wrong with the world. And this is, I think, motivated his life's work. And I think it should be something that we should all be thinking about. The more modern version of this is what Yodi Alakija, the WHO Act envoy WHO Act Accelerator, was asked by New York Times. So how do we achieve vaccine equity? And Yodi said, well, we'll achieve it when we ascribe the same values to lives in the global south as we do to lives in the global north. So this inequity that we see in COVID vaccine coverage and access, to me, is one of the most flagrant explanations of what I call problem one, that we live in an extraordinarily inequitable world. And those of us who are lucky and privileged to be living in the global north are beneficiaries of all the structures and systems that consistently prioritize us and our lives over our friends, families, colleagues in the global south. Problem two is that if we wanted to address this, whether it's vaccine equity or equity in anything else, we are failing because our field that we consider ourselves a part of, global health, itself is deeply inequitable. And that was my presentation to you 2 years ago. And that is that global health is still centered on those of us who hold power and privilege. And it is kind of focused entirely on our generosity and our saviorism. What can we do to save the global south is often how things are portrayed in the global health field. And it's not shocking that it has that flavor, because we all know global health was born out of colonial medicine and white supremacy. But even today in 2022, it's neither diverse nor truly global. And if you don't believe me, just go look up the Global Health 50/50 report that was released last week actually, on composition of 2,000 board members in all global health organizations. And you will find that practically very few people on global health boards of any organization are from the global south. So global health is neither diverse nor truly global. And every aspect of global health is dominated by individuals like us, that is, people who are based in the highest income countries, whether it's publications, whether it's grants, whether it's money, whether it's awards, whether it's journal editorial boards. It's the same story that gets repeated all over again. And this is true in 2022 as it probably was 100 years ago. And so this paper, which we wrote at the invitation of Eric and Mike and others who compiled a series in PLoS Medicine, this graphic is my and our take on what we think is wrong with global health, that it is just too centered on people who hold all the power and privilege. And it shows up through these intersectional oppression systems, coloniality being just one, capitalism, patriarchy, racism, lack of diversity, equity, and inclusion, white supremacy, saviorism, so on and so forth. So we kind of have a pretty decent diagnosis on what is wrong with global health and why it is so inequitable. The problem is, what do we do about this? That has been what I've been focused on in the last 2 years or so. I think the problem is increasingly visible to everyone, and I'm sure you heard this in your Decolonizing Global Health seminars. Pretty much every university, every global health conference has had these plenaries. The real issue, and I think that's probably what Mike asked me to tackle in this seminar, is what is it that I can do? What is it that you can do? What is it that UCSF can do? What is it that McGill can do to tackle these power asymmetries that are so visible to us, right? It's in our face, we know it, we know it's factually true, and the vaccine inequity just merely reminds us on how deeply power asymmetric all aspects of global health are. So the question then should really be, can we do something at all to save this, right? Can we do something to make global health an inherently more equitable field? And so in my writings, I've been thinking about it in 2 ways. One is, what can we do at the individual level? What is it that Madhu Pai can do with no help or support from McGill or my boss or my funding agency or anyone, right? Something that is in my hands. But what is it that McGill can do? What is it that UCSF IGHS can do? What is it that the Gates Foundation can do? That is an institutional issue that we should discuss as well. I think without tackling one, I don't think we can change institutions. Individuals have to change, and individuals have to make an effort. And in that quest to think about what I can do better myself has led me to investigate further this pathway which I see for myself, which is allyship. So in our piece, we said global health practitioners like you and I in high-income countries must embrace a modest view of our own importance and master the art of allyship, where we see our roles in global health as allies or enablers rather than as leaders. So now it was this, I wrote this almost 2 years ago with Shea Bimbola, but I don't think until recently I truly understood what allyship is. And I'm still understanding what allyship is, but I'd like to share with you what I have learned. And I'd love to discuss during the Q&A what this could mean for people like you and I. When I say you and I mean people like us who are privileged, who work primarily in the global north, and who are extraordinarily privileged to be at UCSF, McGill, so on and so forth. And I think my own understanding of allyship has improved immensely since I went through several hours of training, structured training in privilege, anti-racism, anti-oppression, and allyship. If you folks have not gone through such a training, I would very strongly recommend this. In fact, I think it should be a part of any global health program or school, and it should be available free of cost to anyone who wants to go through that kind of training. So one of the things that they'll make you do if you attended these trainings is this is typically called a power and privilege wheel. So you can check off where on this axis you would belong. For example, anyone who is marking themselves towards the center of the wheel, the orange part of the wheel, is at the core of power and privilege. In other words, they have immense privilege, often unearned, that is putting them at the center. And if you check yourself off furthest away from the center, that means you are dealing with some kind of marginalization or oppression. For example, if you're Black or if you're Indigenous, you would be right at the top where you suffer oppression on because of your skin color. And if you're white, that automatically puts you at the center of the power and privilege. So if you're white, if you're male, if you're cisgender, if you're a white settler, if you're a European heritage, you're a Christian, you are robust, you don't have any disabilities, all of them put you right in the center of the power and privilege. That gives you immense power and privilege in all aspects of life, certainly true for global health. And when I went through this training, honestly, I wasn't convinced that I would end up at the center, right? Because I saw myself as an immigrant, I saw myself as someone who was born and raised in India, a person of color, so on and so forth. But when I finished the training, I realized I'm extraordinarily privileged in pretty much every way, probably with the exception of skin color. It puts me right in the middle of that wheel. And when you understand really how privileged we are, it opens a pathway for understanding what allyship could and should look like. So from an intersectional lens, given that people can be at once privileged and at once oppressed on another dimension, from an intersectional lens, here are the things where allyship could help. For example, white people in global health could and should be allies to Black, Indigenous, and people of color in global health. Global North folks, me, you at UCSF, must be allies to our colleagues in the global South. Men in global health, that I count myself, must be allies to women. White women must be allies to BIPOC women. Cis heterosexual folks must be allies to LGBTQ. And you can see, because this is intersectional, this list goes on and on and on. And I have spoken to people in each of these axes in writing this piece that I would strongly recommend that you all read, not because I wrote it. Honestly, my contribution here is virtually nothing. I've interviewed more than 20 people from around the world to write this piece on what allyship and global health could look like. And I will walk you through the highlights of this article, but if you can read it, there are links in the hyperlinks in the article, which will lead you to some terrific resources if you wanted to go further in your journey of education. So what's allyship? And I'm sure some of you have learned about allyship if you have been actively working on anti-racism. And this is no different from that definition that you would have seen in another context. An active, consistent, arduous practice of unlearning and re-evaluating in which a person of position of privilege and power seeks to operate in solidarity with the marginalized group. What allyship is not, which I think is also important to think about, that it is not an identity, right? We don't say I'm an ally. We say we are practicing allyship. It's a lifelong process of practice building, building relationships based on trust, consistency, and accountability with marginalized individuals and or groups of people. And it is not self-defined. So I don't say, for example, that I'm an ally. I should be recognized by others as an ally. It's not about acting out of guilt, but rather out of a responsibility. And it's definitely not about saving others. It's about seeking to work in solidarity with others. And the definitions keep going. Each person that I've read has a slightly different take on it. So for example, Evelyn Carter says, allyship is a verb, not a noun. You can't simply be an ally. You need to constantly practice being an ally. And then you need to use your identity and privilege to make change happen. So in terms of roles, the Anti-Oppression Network says that our job is to act out of a genuine interest in challenging larger oppressive power structures. What could they be in global health? It's exactly what I told you, that every aspect of global health currently is structured to benefit people in the global north. And if that's the oppressive structure that we seek to change, then that is what leads us down the path of allyship. We see a problem and we want to change it, right? So we are here to support and make use of our power and privilege for the people we seek to work with. We turn the spotlight we are given away from ourselves towards the voices of those who are continuously marginalized, silenced, or ignored. And we use all opportunities to engage with people with whom we share an identity and privilege. For example, me speaking to you about allyship is an example of this. I'm assuming most of you are based at UCSF and I'm based at McGill. We are all based in global north institutions, and we have to talk about this within ourselves because we need to engage more and more people like us. So responsibilities for allies. We constantly, actively acknowledge our power and privilege and openly discuss it. We listen more and speak less. Definitely very important in global health. We resist the urge to save the people we seek to work. We take direction from them and not the other way around. And we certainly don't expect to be educated by others. We continuously do our own research. And it goes on to say that we build our capacity to receive criticism and act on them. So allyship is a process by which I expect to get called out. I know I've been called out, and I need to be accountable, and I need to sit with the discomfort that comes from it. And I get used to being challenged and hurt, and it's a difficult process. So we embrace the emotions that come with this kind of work. That we don't center our needs are secondary to the people we seek to work with. And we definitely do not expect awards and plaques and medals for being allies, because people are confronting with oppression every day of their lives. And as people of privilege, we don't need yet another medal or an award to tell us that we are doing allyship. Now, I want to kind of dive a little deeper. What I realized is that when I read about allyship, this is an amazing book, if any of you are interested in reading it, Against White Feminism by Rafia Zakaria. I think the central thing about allyship is that you have to cede something. You got to give up something. Cede space, vacate the table, pass on the mic, give up your opportunity, give up money, power, voice for the people, and for us, people like us who are in the global north, to experience a deprivileging of our perspectives, because we are so used in global health to constantly be at the forefront telling others how they should be running TB, malaria, or COVID, or whatever. So that's a very uncomfortable thought for us, that we take a back seat and experience a deprivileging of our perspectives. But if you don't cede anything, then I have a feeling that's not real allyship. It could be a performative allyship, but it does not really reflect true allyship. And that's exactly what Tiffany Jana goes on to say, that you can be an ally and do nearly nothing. You can call yourself an ally, but when push comes to shove, you're not willing to give up anything, and you're certainly not willing to take any risks in the work that you do. That probably is not really allyship. So a whole bunch of people are now telling us that it's probably not enough to be an ally. It's great to be an ally. It's good to start down the pathway or a spectrum of an allyship. But then they are asking us to actively think about how we could be an accomplice or a co-conspirator. So what's the difference? I think the biggest differences are captured in these quotes. Britt Hawthorne says, being a co-conspirator means we are willing to disrupt, build, and when necessary, dismantle for the future that we want to see. And Jana says, what separates co-conspirators from allies is the willingness to put yourself on the line, whether it's assets, reputation, time, connections, or other resources. Co-conspirators always have a skin in the game. So I can, depending on how we do on time, can offer many concrete examples that we can discuss and learn from. I find allyship much easier when I think in concrete terms. And I can give you examples of things that I'm engaged in, and I know a few examples of what others are doing. I think giving examples might make this all much easier for all of us. For example, right now, we could all be advocating for our governments, US government, Canadian government, to dramatically improve and increase donations to COVAX, giving more money to COVAX, and that could be considered an act of allyship. Why? Because we know our colleagues in the global south are mostly unvaccinated, and they are at great risk of death and disability if they do not receive an equitable share of the global vaccine. So this could be an allyship, right? So I am doing that. For example, I've written to the Prime Minister. I have spoken to Canadian members of the Parliament. In fact, I've been invited to present and attend a hearing at the Canadian Parliament on what Canada could be doing on vaccine equity. I've written op-eds. All of them I would probably see as an act of allyship. But if I wanted to do more than this, then I think we need to ask ourselves, anything we can do to make low and middle income countries less reliant on our charity, which is the trickle-down model of global health, that we think beyond the charity model and we think about justice. I firmly believe that what countries are asking is not charity, but justice. And what they're saying is, give us the vaccine recipe, we'll manufacture it ourselves. So those of us who are advocating for the TRIPS waiver, which will enable countries, all countries that want to make their own vaccines and be self-sufficient and self-reliant, so they no longer need to rely on Canada, US, or anyone else. That, to me, would be a spectacular example of being a co-conspirator. So I'm actively advocating for a TRIPS IP waiver, and I've taken every chance I can, and I'm pushing the Canadian government, which is currently blocking the TRIPS IP waiver, to come out and do better than we've done, right? So that would be an act of co-conspirators. So I hope this is a concrete, very tangible example. And I know UCSF, IGHS has been doing something on vaccine equity, and I've seen your social media posts about going for bike runs or marathons and so on and so forth, and you're raising money. That could be an act of allyship. But if you can do anything to convince the Biden administration, for example, which has pretty much bankrolled the Moderna vaccine. So Moderna is paid for by your taxpayer dollars. Why is Moderna not sharing its vaccine technology with other companies that need it so that they can make their own vaccine? That would be an example where you would be a co-conspirator because you're pushing for a more of a justice model than a charity model. Now, here is another example. As a male in global health, and I know based on data, men dominate global health. There is no question about it. Every single major global health institution is led by men. And I think you see this in institutions, universities, editorial boards, you name it, men dominate global health, and men in high income countries absolutely dominate global health. So I've written a piece on what I am trying to do as a male in global health to lean out and pass on the opportunities that I get to women, especially women of color in the global south. So I would say by now, having done this, when did I write this? I wrote this in 2020. By now, it's getting easier and easier for me to lean out. And I do this intentionally, consistently, and I can tell you that it's not difficult. Of course, I'm able to do that in some ways because of where I am in my career stage, and we can talk more about that in terms of what young people can do versus what established people can do. But in my blog post, I have given several concrete examples of what men can do to be better allies in global health. The other area that I'm personally impacted, I'm not sure how many of you will relate to this, is that I see myself as a double agent in global health. So this is again a piece that I wrote, and I've interviewed like 24 people from around the world in writing this. So someone like me who straddles two worlds, I was born and raised in India, I did my medical training in India, then I spent my time in the Bay Area, and now here I live in Canada. I see myself as in some ways a bridge between two worlds, but at the same time, my privileged position now makes it very challenging for me to know what my boundaries are in my global health work. So here is a quote from that piece. The double agents like me are not always clear who we can represent or speak for. So do I still speak for India? But I don't live in India anymore, right? And can I truly represent the country that I have left? And if I did, will I end up taking away the voices of people who need to be heard? So if you want to hear about someone from India, am I a poor substitute for someone from India? So these are complex issues, and they are inherently intertwined with the power and privilege that double agents hold, that we may come from the global south, but we're currently in the global north. That puts us in very powerful and privileged positions. And there are many people like me all around. And I'm sure that you have folks at UCSF who have similar situations as me. Another work in progress experiment, so to speak, some of you heard of this, is how we created and are running PLoS Global Public Health. We saw that global health journals are not very diverse. They're primarily run by folks in the global north. And so we've intentionally constructed a journal which flips everything on its axis. For example, the editors-in-chief, Catherine Kyobutunji, is a woman, an African Black woman who lives in Kenya, and I'm a male, I live in the global north. Together, we are editors-in-chief. So right from the start, right at the leadership level, we're trying to be intentional about how we structure this journal. We have about 45 section editors who essentially form the leadership team of the journal. Of the 45 section editors, about 70% are women, about 90+% are people of color, Black, Indigenous people of color, and we have at least 50% of the section editors are living in the global south. This is nothing like what you would see in most global health journals. So every step of the journal is intentional. There isn't a decision that we make that is not deliberate and intentional. And during Q&A time, I can talk to you about the difficulties and challenges we've faced and what our learnings have been. But this is an example of a journal that truly tries to be an ally for colleagues in the global south, people of color, people with lived experience, people who generally don't make it in any global health journal so far. The other area where I can talk to you more about allyship is global health education. So for example, in my Global Health 101 course, I introduced right at the start of the program an entire block, an entire 3-hour session on privilege, power, anti-oppression, and allyship. And I have flipped the course because of this online nature over the last 2 years. Most of my course faculty are people of color in the global south. And that has made a massive difference to how I teach global health. And I can't see why we can't do such things in today's context, where online learning is so much more possible and we can bring a whole host of new voices into our classrooms that we could not have done before. This is not my example, but I am very inspired by this work. This is organizational change. I think Mike had asked me, so what is it that UCSF can do? And I keep thinking about what McGill can do. Organizational change is much harder than individual change. Some of you have seen the reports on structural racism from London School, Liverpool School, Médecins Sans Frontières. Any organization that digs deep will have to confront the realities of these organizations, right? So if you want to make an organizational change, it's much harder to do that, but it'll always nice to look at examples. So Anu Kumar is the CEO of an international NGO called IGHS, which works on gender, reproductive rights, so on and so forth. Anu wrote a piece 2 years ago on white supremacy in global health, which got her thinking hard about her own organization. So she's made major changes in her organization, and she's written a piece in BMJ Global Health explaining how she's done it. So she says, after nearly 50 years as a traditionally structured international NGO, IGHS is on a path to dramatically change the way we operate. We're an international reproductive justice organization with offices in 16 countries, working to ensure that abortion and contraception is accessible to all. That mission will not change. But what we are transforming from a traditional hub and spoke organization with a power centered in the USA to a network organization with authority, power, and leadership dispersed and shared across the countries where we work. So this is quite revolutionary and radical for an American headquartered organization to decentralize power and leadership. But if she can do it, if they can do it, I think we can all think about this as one particular model. So I want to end, and I'll leave questions for all of us. I think the piece that we wrote on allyship ends with this quote by an indigenous elder called Leela Watson. And her quote goes as follows: if you have come to help me, you're wasting your time. But if you come because your liberation is bound up with mine, then let us work together. I think I'm starting to understand that allyship still has this saviorism way of thinking or envisioning it, that if I am your ally, I'm here to help you. I think Leela Watson and others who I quoted in my piece are telling us that's a wrong model of thinking about it. I'm not here as an ally to help my colleagues in the Global South. I'm saying together with my colleagues in the Global South, we will dismantle the oppression that is inherent in global health, right? Which I think is acting in solidarity as collective liberation, that we are all bound up. So oppression of anyone, anywhere is bad for all of us. So from that perspective, it's the same as saying racism, even if it doesn't affect some of us immediately, will affect all of us eventually, because a racist society is a bad society. It's an oppressive society. And therefore ending racism is good for everyone, white people included. And white people will then need to seek collective liberation from a racist society or a structure, and therefore allyship is what they should be doing. So I'm starting to think that collective liberation is how we think about it. So to go back to where I started on vaccine inequity, let me see if I can put it in a way that will make this clearer. Vaccinating the world, so the high income countries that are currently hoarding vaccines, refusing to donate, not backing intellectual property waiver, they're fundamentally not understanding that our own safety and long-term security is bound up with our friends, colleagues, brothers, sisters in the Global South. There is no such thing as keeping the global north safe when half of the world is unsafe. So our liberation, collective liberation, comes when we protect the whole world. And therefore the right thing for us to do in the global north is to give vaccines, give technology, share the recipe so that the whole world is protected. Just as there is no way of saving just the San Francisco Bay Area from climate crisis, we save the entire planet from climate crisis. There is no way to just save one part of the world because the whole world is in a crisis. So collective liberation to me comes from a thinking of genuine global citizenship, that there is no way of saving one of us, one country here, one province there. We got to think about it truly from a global solidarity perspective. So with that, I thank you for your time, and I'm very happy to take questions.
Thank you so much, Madhu. It's always a pleasure to hear you, and provocative, interesting, and always stimulating stuff. So let me turn it over to Rebecca now, and she can start off the questions. And again, thanks. We'll go to noon or a little before noon, and I'll come back and announce the the May 11th upcoming grand rounds. So Rebecca, take it away.
Hi, that was an incredible talk. Thank you so much. I have a question kind of from me, but also just my classmates in general as master's students. What are some ways that we can specifically act in solidarity for collective liberation as kind of upcoming practitioners? We're all, on the younger side, freshly out of undergrad, a lot of us. So that would be my question.
Great question, Rebecca. So one thing that you can all do, I think, is go through the kind of anti-oppression and power and privilege training that I underwent. And if George or others are interested, I can even suggest trainers who will do a brilliant job. And even like a half-a-day workshop would be immensely helpful for you, especially before you folks go to do your field work into whichever country that you might be going to. So that's one thing that I think the master's is the best time to learn this, not I think I learned it too late in my life, although there's nothing called too late in life. I wish I had learned it when I was at Berkeley, for example, right? That's where I learned, obviously, epidemiology and statistics and other technical areas in Berkeley, but nobody ever taught me what anti-oppression, anti-racism, power and privilege would be. So that's one concrete suggestion. 2, make sure none of you ever do parachute research, right? Take data from some country, write it up without a single author from that place. Because if you did that, that would be the extreme opposite of everything I've told you what allyship should be, right? If you had thought about allyship and if you're practicing reflexivity in allyship, you would never, ever pull off a parachute research type of a paper, right? The fact is we still keep seeing such papers, right? There isn't a day when I don't see that as an editor. And it worries me that people are simply not even thinking about it, right? How do you end up writing a paper on, I don't know, some disease in Congo and not a single Congolese author on the paper, right? It just shows a shocking lack of reflexivity in global health. And that it's fact that it's happening in 2022 should absolutely make us all pause and say, what the hell is wrong with this field, right? So as a master's student, if you are thoughtful about it, you would have such conversations with your supervisor to say, okay, I'm going to Guatemala or I'm going to, Sierra Leone for my thesis work. How am I making sure that this work is of value to my partners in those countries, that I'm not taking away somebody else's data? And how do we equitably recognize the partners who may have collected the data for us in Sierra Leone or India or Uganda or wherever, right? And come up with creative authorship models. For example, if my master's student is a first author on a paper, I typically make sure I'm not the senior corresponding author. It's my Indian partner who's a senior corresponding author, right? So we make sure that the two important positions are adequately represented by both McGill and the Indian institutions. So there are very many ways by which you can constructively make a change, even at the master's level. You obviously need your supervisor on board, but I think it's great that UCSF has done this series of talks over the last 2 years since I first came, and I'm sure even before, but I think this is possible to do. It's not impossible to do.
Thank you. Yeah, my capstone's actually on authorship, so that's really interesting to me. That kind of leads into another question from one of my classmates, which is just about how can we evaluate, if we're going to international settings, how can we evaluate like the validity of us being there and critically examine our work in those settings?
So I think, again, us going to a low and middle income country for anything that we do, be it practice, be it clinical work, be it research, we got to start off by saying, have they truly seen value in that collaboration, right? In other words, are they inviting us because we have something to offer, or are we imposing on them just to be collecting and furthering our own work? So I think it was CUGH conference. So there is a whole paper, and I'm sure we'll find it and put it in the chat box, just published like a month or two ago by CUGH on what they consider equitable partnerships in global health, right? So a lot of people are asking similar questions, like how do you judge that this partnership is equitable? And there are ways to judge it. For example, if, I don't know, 20 people from UCSF are going to Uganda, but you've not received a single Ugandan trainee at UCSF, that would be a huge red flag that you're not seeing this as a reciprocal agreement, right? Something that I worry about a lot at McGill. And I cannot tell you what a big difference this online education model has made to us, right? In the past, we used to have summer courses and we would invite people from low and middle income countries. And guess what? My own Canadian embassy would not give them a visa. That's how messed up, reciprocity is. US is a very hostile place to get a visa to come to. Canada is very hostile. UK is very hostile. So I don't think our governments necessarily understand the importance of reciprocity. The minute we switch to online degrees and online learning, we dramatically increased the number of trainees that we could take. So there are ways to creatively make sure we're being truly equitable and reciprocal.
Awesome, thank you. And then I have a question from Mike. It says, thank you for your insightful comments about organizational change. How can academic institutions like UCSF incentivize allyship for its faculty? Examples like authorship, grants, and what would that look like?
So this is a question I get asked a lot. So for example, would McGill or would UCSF, when we apply for tenure and promotions, take our allyship work seriously, right? Because our institutional environments are such that we are incentivized to always be the lead author, for example, right? If we think like that, then I think true equitable partnerships are probably doomed, right? You got to start rethinking what that model means. And that can come when leadership believes that this can be done, right? It's hard for junior people to speak up against these policies. Structural changes have to be made. Secondly, look at all of these reports. I just spoke about the new report on the London school, or new report on the Liverpool school. Now, what are these institutions going to do in terms of making sure they themselves are diverse, right? So if I look at the McGill faculty, I'm just blown away by our lack of diversity in terms of indigenous populations, right? I don't have a single indigenous colleague in my school, the entire school, right? And so this is massive because I really don't think we can decolonize anything if we are that internally non-diverse. And I just was stunned by the Global Health 50/50 report that came out two weeks ago on how non-diverse global health organizations are. So I think universities are an example of a global health institution. So just as we've learned how badly McGill is performing, UCSF and other institutions need to do the same. And you got to go back to the drawing board and make sure you're recruiting diverse faculty at all levels, right? Then I think you are more likely to succeed. Authorship, I think, is much easier to deal with. Why could we not think of a joint first authorship on all papers, where there's someone from the global north and global south who's an equal first author, or find a way, as I have found, I've always given up my senior authorship position, because if it's a student and they need to be using it for their thesis, then they have to be the first author. But even that, we should start accepting joint first authorship on student thesis. Then suddenly this problem becomes less tractable. I think we have these old-fashioned ways of thinking about thesis means you have to be the first author, right? It's like dictated by, I don't know how many generations above us. There's no reason why we can't challenge any of that and try to do things differently.
Well, let me jump in. We're at the witching hour. I just can't think about how many papers I've been seeing recently that have multiple, sort of co-first authors. I think that's a great solution. Madhu, you point out, you've been terrific as always. Thank you very much for coming. Rebecca, thank you very much. Very insightful. I'll point out that our next Grand Rounds is on May 11th at noon, and where we'll have a presentation from representatives of the HEAL initiative, which is Health Equity Action and Leadership. This is buried within, I think of it as being buried in the Division of Hospital Medicine in the Department of Medicine, but it's much broader than that. And they've been really instrumental in pushing a global health agenda in clinical matters as well as in public health. So please come and join us again on May 11th. Madhu, I note you're wearing a UCSF t-shirt. That's very cool. We're feeling very solidified with yours, whatever the verb is for solidarity.
Mike has got his hand up.
Mike, yeah, I was going to just call on Mike since he was a sponsor of this, and just ask him for closing words.
No, I just wanted to sort of echo the sentiments of Rebecca. Madhu, thank you so much. You have been a really erudite leader in advocating for sort of a decolonizing movement. And we're really grateful for your contribution and sort of provoking institutional and personal change here in San Francisco. As a UCSF alumni, we are also especially grateful that you would come back and speak to us. So thank you so much, Madhu.
And so many times too. So thank you very much. We'll see you on May 11th. Madhu, if you get out here, please swing by to say hello. Take care.
Thank you. Bye, everyone.
Bye, everyone. Thank you.